Welcome to Men's Mental Health Asylum Crisis. Thanks so much, each of you, for joining us tonight. This is an important event. The topic is obviously intrinsically important. It's a life and death topic. And it's important that we have this dialogue at Ryerson campus and at other universities and colleges across Canada. So thank you for being a part of that. We're going to go very quickly to our keynote address by Dr. Robert Whitley, who is actually joining us remotely because he's at a men's health conference in Australia this week. So he will be speaking for 20 minutes to introduce the topic and the theme of tonight's event. And then we've lined up a really special group of people coming from a number of different backgrounds and with associations with a number of prominent community health organizations across Toronto. So we're going to hear from them as well. That's why we've got some microphones lined up there. And I'm very proud and excited to announce that we've got both students and faculty here from Ryerson to speak on this topic as well. So we're going to hear more from them after Rob, but very, very quickly I'm going to ask Sarah to come up. Sarah from the Ryerson Men's Issues Awareness Society, to say a very quick word.
Hi everyone. Again, thank you all for coming and for your support throughout this journey of ours. I just quickly want to say that we are still in process of, for any Ryerson students that are here, we are accepting signatures and sign-ups because we need a certain amount of students in order for our group to be rectified with these student meetings. So we'll be passing around this sheet here, and if you are a Ryerson student, you can just jot down your name. And if you are still interested in being under our email list for updates and just the general events, you can also just put your name, your email down as well. So, thank you.
So we'll pass that around right now. I think this is intense. And we'll hear more from Sarah and other students and members of the Ryerson community. But without further ado, because we don't have a lot of time, I'm going to go straight to Professor Rob Whitley, psychiatry professor from McGill University. Rob, you have the floor.
Echo, so I'm going to take my earplug out and just put my microphone here. So if anyone wants to stop me, they're going to have to put their hand up rather than speak. Okay, thank you everybody for the introduction. Thank you, Justin. As Justin said, I'm actually in Australia at a men's health conference here. It's a 2-day national conference. And I thought this is a good place to start the conversation a bit, because at this conference, there's been academics, there's been community workers, there's been mental health workers, there's been social service agency workers. It's been completely normative, and men's health research, men's mental health issues here in Australia just seems to be completely normative. The idea that somebody would protest these things, or that journalists would take umbrage to the fact that men are getting together and talking about these issues, just is completely off the radar here in Australia. And I just hope that in Canada we're getting to that stage as we speak, and in the future that we can talk about men's health, we can talk about men's issues, and people will recognise this as being important for the well-being of men as much as for the well-being of society as a whole. What I wanted to do today, because I've only got 20 minutes, is really talk about 3 kind of men's mental health problems, and then 3 men's mental health solutions, and then close at the end. And maybe there will be a bit of time for questions. I'm in a space here where people will be coming short at 11:30 my time, so I'm going to try and state as many questions if possible, but it might get noisy, so we'll cross that bridge when we come to it. First off, I wanted to talk about a syndrome called failure to launch. So failure to launch is an important phrase that people should remember here. Failure to launch, to define that syndrome, so-called syndrome, means young people who stay in the parental home beyond the age of 18, 20, 21, 22. And statistics show that failure to launch is increasing across Canada to the stage now where almost 50% of men in Canada in their 20s live with their parents. So this figure is much more reduced in women. It's something like 33%. And there's various hypotheses as to why this is, and more importantly, what is the impact of failure to launch. One of the hypotheses is that there's been a decline in jobs for men, the type of jobs that men traditionally did, manufacturing, forestry, fisheries. There was an article on the CBC website, also repeated on the National, a couple of weeks ago, just before I left Canada, which showed that 70,000 of those types of jobs have been eradicated from the economy in Canada, especially in kind of smaller towns, in mill towns, towns like Hamilton, in small towns across Ontario. There's been a massive decline in those kind of industries, so we have more and more men living at home with their parents to the age of 30, beyond the age of 30. Their unemployment of that age group is also twice the national average. Now, we could call that a social issue, but I would call that a mental health issue as well, because we have a framework which we call social determinants of health. In social determinants of health, we recognise that social factors influence health factors. I'm going to link that first thing that just said failure to launch. Okay, someone's waving at me.
Rob, can you hear me? Can you move the mic a little bit further from your mouth? We're getting a lot
Oh, yes.
yes.
Okay,
Got
sure.
that? Okay, thanks.
Okay. Is this better?
Much.
Yes.
Thank
you.
Yeah, so the failure to launch, I would like to link that to the second problem that I would like to face. And thank you, the gentleman at the second row there. Suicide. So, as I've written about a lot, 75% of suicides in Canada are made by men. That's almost 50 a week. That's 1 every 3 hours. So this is a very scary statistic. Professor Dan Milsker at University calls this a silent epidemic of male suicide. That statistic is a tip of an iceberg. Underneath the tip of the iceberg is what I call slow motion suicide. So slow motion suicide. That basically means men who are kind of slowly killing themselves through negative behaviours. This includes things like substance abuse, smoking, alcohol abuse. We know that over 1 million men in Canada suffer from what we call substance use disorder. Like I said, this includes addictions to drugs, cigarettes, alcohol. And what I would like to do here is to link kind of substance use disorder, what I call slow motion suicide, and more acute suicide with failure to launch and the damage to the economy that we've been seeing and the decline in traditional men's jobs, because I think these are all phenomena of an underlying problem, which is kind of the role of men in the world, an economy where men's traditional skills have been changing house prices, which I know in Toronto is a massive thing to try and buy your first apartment. These kind of things that used to bring a lot of meaning and dignity into the lives of men and women as well. Owning a house, having a job, having a salary where you can support yourself. We just can't really take these things for granted anymore. The statistics show this. So they're my first two kind of problems. The third one I'd like to talk about is mental health service utilization. So every province, every town, city has mental health services, psychologists, psychiatrists, social workers. We can statistically examine who uses these services, and we know that men are much less likely to use mental health services than women. And this has also been linked to suicide, substance abuse of men are not asking for help and not going to these official services. There's two ways of looking at this. The traditional way in academia has been to say, well, men are stubborn, men are self-defeating, men don't like talking about their emotions, they don't like admitting their problems. This conference I'm at in Australia yesterday, every academic and researcher who stood up said that's actually not the case. Men do talk about their problems, they talk about them to their close friends. Men are happy to talk about emotions. When they have a problem, they think that through problem solving and self-reliance, through certain skills, they try to address these problems. And the academics at this conference have actually been saying, well, it's actually not men that is the problem. The problem is the configuration of official mental health services. In other words, official mental health in Canada has a variety, but the tendency is to rely on giving somebody a pill or to see a psychologist for 60 minutes and talk about your problems, a complete stranger. And the men in research studies tend to tell us that they would prefer a more kind of action-oriented approach, where they can do things, where they can have more camaraderie, more what we call peer support, where men are in a group, talk about their problems together, supported by a clinician. And we see these interventions more and more in certain social work practices, occupational therapy. So in other words, one way of trying to deal with this problem is to say men should be rewired because they are too stubborn, They don't talk about their problems, and there's something in the, whether it's culturally conditioned or biologically conditioned, the kind of hardwiring of men. The other approach is to say that mental health services should be rewired because they don't respond to the needs of men, and the kind of default options, the kind of, some people argue this, and I'm not saying I'm saying this, it is the default option in mental health is a middle-aged, middle-class woman, and it doesn't attend to the needs of people like Aboriginal people, gay people, and even men, for example. They're the kind of three problems I wanted to talk about. I wanted to kind of end on a more positive note or a high note and talk about three solutions or three approaches that tend to be working. The first is, I don't know if there's any journalists in the room or any media, but I've been working with the media since 2010, trying to get them to report about mental health issues differently, to be more compassionate, to use more appropriate language, more accurate language. And I did a study a few years ago where I found that when the media talked about a woman with mental illness, they did actually take that approach. They were more compassionate, they would provide more context, they would provide more background in a story. However, when it was about a man, the approach was much more punitive. If there was any crime involved, for example, it was much more lock them away and throw away the key, which you may have seen recently in the coverage of Vincent Lee in the media, who was recently discharged from mental health services. I've worked with a number of organisations to produce these media guidelines called Mindset. 5,000 of them have been distributed across Canada to judge the newsroom. These guidelines actually have suicide guidelines in them, which recommends how to appropriately report suicide, what kind of context to give, what to do, what not to do, and there's 14 guidelines. You can find them free as a PDF online. What I did is I did an evaluation. When Robin Williams killed himself a couple of years ago, I looked at the Canadian media to see how well they were adhering to these guidelines. So some of the guidelines are do link this to broader social issues, respect the privacy and grief of the family, include reference to their suffering. And in my study, I actually found that the Canadian media were really adhering to these guidelines very well. So to me, that's a kind of positive sign in terms of mental health and men's mental health, that the media are changing, they're recognising the need for compassion, for appropriate language, for accurate reporting, and that's something which we should collectively, in a way, be proud of and try and encourage. And I encourage everybody to kind of work with the media in terms of mental health, suicide. The second solution I wanted to talk about was what I call transitions. So we know that a massive time of vulnerability for men and for women, but more intensely for men, is what we call life transitions. This includes divorce, it includes bereavement, it includes being made redundant from your job, it includes veterans being discharged from the army. It even includes people making career changes. So there's a sad suicide here in Australia. Everybody's talking about a professional rugby player who was 35, coming to the end of his career, loved his career so much, was apparently very worried about what he was going to do. And this is a bit of speculation, as it's not clear, but the hypothesis is that he killed himself because he just didn't know how to make this transition. In Canada, 40% of marriages end in divorce. Many people in the room are probably divorced, and you know from personal experience, it can be a very difficult process. We know that these transitions, the risk of suicide and the risk of substance abuse increases dramatically. So what researchers like me and people who want to take action are trying to do is to try and encourage specific services, specific action during these transitions to provide support. We're trying to encourage official mental health services to pay attention. We're having variable success, shall we say. But where we're finding a lot of help and a lot of money is in the non-profit sector, Salvation Army, Movember, these kind of organisations. So I got some money from Movember earlier last year, to provide support to men who are going through separation and divorce, who were having difficulty. And this was, we got money to create a video project. We taught them how to use video cameras and to train in video, and then they then made a short documentary. So this was a really helpful, action-oriented project. It wasn't a special therapy, it wasn't giving people medication, it It was actually telling them to come in once a week. We train them in a new skill, which men seem to like, in video camera report, etc. And they found it really helpful. They met once a week, did like a mini evaluation, and like I said, that kind of transition sport seemed to be really good. And again, I'm not really sure who's in the audience, but if you have the power to think about new services, or you have your hands on the purse strings, that's the kind of thing to just kind of could be really important to provide that support during transition. My third and final point is the importance of strategies. So Canada did not have a mental health strategy in 2012. It was the last G8 country to have one. Canada still does not have a national anti-suicide strategy. Australia does not have a national anti-suicide strategy. They both have higher rates than analogous countries like the UK or New Zealand, which have had national strategies. It's to talk about provincial. Actually, before I say that, what I should say is I think strategies are very important. And what is a strategy, and who has the right to have to create a strategy? We were talking about this yesterday here in Australia, and people have said, well, if the federal government or the state governments are not writing strategies, we should write our own. And I was really inspired by the Australian main LGBT organisation created their own national anti-suicide strategy for gay, lesbian, bisexual people. And it's a beautiful glossy brochure. It's got targets, it's got concrete action points. It's what I would call a horizontal strategy rather than a vertical one. It takes a subgroup. We could have similar ones for veterans. We could have similar ones for Aboriginal people. It would be great if Canada did develop a national anti-suicide strategy, but in the absence, there's no reason why people in the room who have contacts with municipalities, who have contacts with the provincial government could try and lobby and try and get strategies at the provincial level or at other levels. What evidence do I have to support this? The Quebec government had a provincial anti-suicide strategy in 1999. At that time, Quebec had very high rates of suicide, rising rates of suicide. This strategy had concrete action points, had targets, it had who, when, where, it was evaluated. And what we found was, once the strategy was implemented, suicide rates stayed and actually decreased. So I just think it's vitally important, if you know, to create these strategies, like I said, whether they're vertical or whether they're horizontal. They're the kind of main points I wanted to say, three kind of problems, three potential positive points or solutions. I would just like to say that mental health, men's mental health, is always a brick by brick process. We're kind of, it's like building a house or building a cathedral. Everybody has their role to play. If we all put in a brick, we do research, we take action, we follow that cycle. I'm really thrilled to see on the screen here probably like 100 people in this room who care enough to come and listen about this. I imagine you're from a whole range of organisations. As I said, the more people do, the more we talk about it, the more things can happen. And if you need inspiration, look what's been done in Australia. People are taking action. The whole Movember charity, many of you may know, is an Australian charity. There's events like what's happening at Ryerson tonight happening regularly. Journalists are covering this, helping raise awareness, bring attention. The idea that somebody would protest this kind of thing is ludicrous. So I think that's all I'd like to say. And my space is empty, so if there's time for questions, Justin, I'd be happy to take them. Thank you.
How much time do you have?
I have a lot of time, but it's more, I'm in a space where there's another event, but there's nobody here yet, so I can tell you when it gets too crowded or just.
I'm going to lead in with the first question, if that's okay, because I'd like to get you to comment on, since we're at Ryerson, this is an environment that has to do with youth, and the goal really for tonight is to discuss strategies that would be effective in the context of a university or a college campus. Can you comment on whether you think a men's health support group or some other kind of support services would work in a campus setting, and if so, how they can be tailored to really attract and benefit male students on campus?
Sure. I think any health group on campus is a very useful intervention. So in terms of mental health, so at university there's at McGill there's an organisation called jack.org which provides support to people with mental illness in general. There's a peer support centre where people can go and talk to people who have experienced depression when they were younger or eating disorders and get support. I think any analogous group, like any subject demographic is very useful. So that is kind of theoretically driven. We know from evidence that peer support is helpful. You can talk to people who are like you, who have experienced something similar to you when they were younger or just recently, and then they can talk you through the process. In Australia here yesterday, I was at a seminar where they have something like that, it's called Top Blokes or something like that, where men, it's like Big Brother, Big Sister, where like older guys mentor the younger guys who are having problems. So clearly, theoretically, and evidence shows that that kind of peer support is useful.
Okay, let's take some questions from the audience. Rob doesn't have a lot of time, so we'll have to be quick and concise. Who has a question? We're going to pass around the mic so we can capture it as in reach. Why don't you mind coming up? If you have questions, you can please come up to the aisle here. Yes, sir.
I like the idea of a national anti-suicide strategy. I'm just a little unclear as to what sorts of points or actions or targets might generally be included in that. Could you clarify or expand on that a little bit?
Yeah, sure. I think these strategies have to be a collaborative process where they should start with a round table of key stakeholders, which should include Aboriginal elders, chiefs, psychiatrists, community members, families who have been afflicted by suicide, etc. So it shouldn't be. Traditionally, what happens with these strategies is people like me, kind of academic professors, who make the decisions, and we should be part of that conversation that should come from the whole of society, people who are affected. The Quebec one in 1999 was a kind of good role model. It had things like concrete targets, kind of reduce suicide by 10% year on year. It also had action points, so have like anti-suicide workshops in high schools, have counsellors, have people work, like identified mental health experts who people can go to if they're feeling low. Fund help anti-suicide help. In Australia, that's a big thing. They've got this called Lifeline, an anti-suicide helpline for people who are very vulnerable. Things like taking action bridges, so even action items like physical. So if you go to here in Sydney, there's a popular place where people have killed themselves, which now has like high fences, so people literally can't do it there. So you need kind of contact target groups. This all needs to be evidence-based as well. So I would say some of those evidence-based things.
Okay, excellent, thank you.
Thank you.
Any other questions? Well, hi.
Sorry, I'm also a gay Indigenous gentleman that just got out of rehab at a CAMH. I'm just curious out of the members that are in the group and just expanding on that the programs that are neat. A 2-week program that I got out of a treatment center. 2 weeks is not enough. So if you can push on those programs to the psychiatrists or doctors that are out there, the treatment centers that are offered to us. 2 weeks is definitely not enough for someone that just got out of rehab, and we need support services for men's health or even groups that are out there to continue those services, because the work out there begins after treatment, not during the treatment that we are offered or that's given to us in treatment during the program that's offered to us. So any ideas that you can offer to us or to the community that's for Indigenous or for gay men?
Yeah, really good point there. When I made that point about transitions, one thing I failed to mention, which I should have, you just reminded me, is that the transition from rehab or from mental hospital to living in the community, or if you've been in for 5 days, if you've been very suicidal, is a really important transition. And sometimes we spend a lot of money and time on the rehab or the hospital, and then when someone's discharged into the community, there's nothing there. So that again goes into my about having transitional support available. And Movember is funding a lot of the project. I feel that the official services kind of people fall through the gaps quite easily. And again, relates to kind of Justin's first question. I think that's where peer support can be very important, especially if you're a member of sub-demographic, you're Aboriginal, you're gay, you're lesbian, whatever, to have kind of peer support, or an elder gentleman, from a group of people who are like you, who can say, I've been there, day one is going to be tough, day two, you need to, there's certain things, like help with groceries, pay your bills, let's talk back, try and find you some part-time work. So there's this intervention with peer support, like I said, similar people helping each other who are not professionals, is really, really important. And actually Canada in many ways is starting to integrate these into kind of clinical teams or into clinical spaces. Again, much more can be done. I would say kind of peer support and transitional support. And I would say, just in your specific example, the Australian LGBT anti-suicide strategy is like really good, and the organisation there, and maybe if you're involved in the community, it's time for the community to say, well, look, the federal government are not doing anything, we'll do it.
Any last questions? Lori, do you want to comment?
You've probably looked at this, but the relationship between the judiciary, the courts, prisons, can they be built between health providers and the kind of transitions men go through when they are in prison, coming out or going in, and that sort of relationship building with health providers? Because there doesn't seem to be any of that in the prison, as far as I know. So.
Yeah, really good point. I can't say I'm an expert in that area of kind of health or criminology, but from what I do know, what you said is true. It's another transition which is difficult to navigate, where there's not a lot of compassion or sympathy or services. And like the other transitions, a very vulnerable time for kind of substance abuse and other mental health problems. So sadly, I don't feel expert enough in the area to add much more than that.
Well, you have time for one more question, perhaps?
Yeah, I do actually. The space is still empty, so.
Okay, we're in luck.
Yeah, I'll let you know when people start filling out.
Who wants the last question? This is your last opportunity. Yes, please come up to the microphone. Okay, this will be the last question, then we'll let you go, Rob.
All right, thank you.
Hi, Rob. When we are prescribed medication and are changing our lives from addictions, what can help us? Like if we don't want to be stuck on medications, if we don't want to just be shoved in a corner and take medication, when we want to move it forward, what advice can you give me?
What we know from the evidence is that the more normative life someone can lead, the better, the most likelihood is that they will readapt to society and not relapse. When I say normative life, things like having a job, a 9-to-5 job, sleeping 7 or 8 hours an evening, having a few friends, having some hobbies at the weekend. This all sounds maybe a bit trite, but in the old days, we used to think in psychiatry that the best way to help people was to separate them from society, that they were too ill to work, or that if you had substance abuse issues, you should go to like a halfway house, be with other people who have substance abuse issues. What we now find is the more you can get someone back into the normal routines of society, the more they're busy, their mind is off the fact that the substance that they used to abuse, etc. And like I said, peer support from people who have recovered, people who have been in recovery, people who can say, I've been there, done that, I can help you. So I'd say those are the two best pieces of advice. Try and lead a normative life as possible. And if there's some peer support group, I don't know your own personal situation, Alcoholics Anonymous, NA, the kind of group that I've mentioned throughout, I can't see you if you belong to a demographic, immigrant support groups, whatever. I would say that kind of thing.
Thank you very much. Let's hear it for Dr. Whitley. and good luck with the conference.
Justin, I'd just like to thank you for organising this, and it looks like a great crowd, and I'll come to the next one in person, hopefully.
Rob's going to sign out. Bye, Rob.
Okay, bye.
The event isn't ending there. In fact, we've got a very fast-moving night for you. We've got a number of people here. I'm going to call them up shortly from a number of very important social service and community health agencies. So I will introduce them. And the format of the event will be me speaking, hopefully very briefly, and then we're going to roll a 4-minute video. We're going to show you some of the services that my agency is doing under the Center for Men and Families. That's pretty good. So you're going to see a very short video with some of the programs and services that we offer at our center, and you're going to hear from some of the clients, some of the men who have benefited from those programs, and then we're going to call up some folks from the audience to join the panel, and we're going to hear briefly from them for about 2 to 5 minutes each, and then hopefully we'll take your questions and we'll engage in a dialogue. Really, the idea of this evening is we want to move forward. We want to build support services that address men's mental health issues here at Ryerson. And as you heard earlier today from Sarah and Catherine, there's an initiative right here at your own campus to build a men's support group at this school. You can sign on to that initiative, or maybe we can talk about some other creative ways of moving ahead. Can we cue the video? Now, before we play the video, I just want to be clear before we get into all of this, just 1 second, about what tonight's about and what it's not about. So just very briefly, this is about opening up a new space to deal with some serious mental health issues and to provide a positive outlet for men to deal with their problems. We believe, and I think you heard it from Rob very strongly, that the research bears out that when men have a positive space where they can talk about their issues, that they're likely to find healthy outlets to deal with their problems and less likely to engage in risky behavior, which could harm themselves and sometimes harm other people. What tonight's not about is replacing or competing with any services at Ryerson or in the community that are supporting women or supporting other groups on this campus. This is about working collaboratively with existing organizations. There are a number like the Ryerson Center for Student Development, the Ryerson Student Union, and a number of mental health programs already on this campus that are doing a wonderful job. We would like to work with these agencies to develop services that possibly close some of the gaps that still exist. So let me tell you a couple of quick facts that sort of set the picture tonight. One of the facts is that 70% of suicides are men. You heard something to that effect from Rob. Another fact is that there's an existence of a culture of male silence. Isolation, loneliness, and social rejection are all causes that lead to, tragically, cases of male suicide. So because men are socialized to suppress their emotions, very often they don't seek out help, and they may very well engage in harmful rather than help-seeking behaviors. Now, before we play the video, Lauren Amity, who's a professor here at Ryerson, has run over from class during his break, so we're going to squeeze him in right now. Yeah, Dr. Amity is a psychology professor here at Ryerson. He's going to say a few words about this initiative.
Well, I'm not just an instructor at Ryerson, I also have clinical practice. I also do many assessments for the courts and for children's aid societies across Ontario. And I've seen the damage that that can be done when somebody does not feel empowered, doesn't feel right, they feel stigmatized if they try to seek help for many different issues. And one of the issues I see a lot, especially with Children's Aid Society, is mistreatment of children. And this is a genderless issue. Males, I don't know what stats are being thrown out yet, but I mean, we know the fact is that males and females are equally susceptible as children to being, abused, mistreated in many different ways. And we know the fact that, the research is very clear that early childhood abuse, if not dealt with, can have a lifelong impact on the development of the brain, on your personality, social, interpersonal functioning. So when I met Robert Samry a couple months ago, we were part of a think tank to try to help First Nations people. He asked me if I would join this group because this is a group that is not getting enough, coverage, so to speak. And when I've heard so many young men, a lot of my students, my young patients, when they do say, you know, like, I'm feeling this way or that way, I feel lost, I feel helpless, they're told, suck it up, oh, poor white privilege, or now you know how marginalized people feel. That type of language isn't helpful. It just further pushes people to the fringes. And that's, unfortunately, with social isolation, when people are most vulnerable, as Justin was saying just before I got brought up. So I believe that, I'm in the media quite a bit, so every time I get a chance to talk, I do try to bring these issues forward. Even if it's not really related to the talk, I will kind of squeeze it in and try to raise the issue. Because I think that anything that can be done to help destigmatize any of these issues and help people feel empowered to get help when they need it, or to be able to provide help to other people, whether it's being supportive, whether it's helping them navigate through a very difficult healthcare system, I think that's important. So anything that can be done to further that cause, I'm happy to volunteer my time and you know, lend my expertise and lend my one card, which opens the podium. So, I'll be giving a talk on March 21st at the U of T. I guess it'll be up on the cafe website, I think, on 7 o'clock, I believe, on Tuesday night. I think it's, okay, so I'll be talking more about this and what people can do in order to help themselves and help people around them. And again, I try to take the gender out of this. It's not a gender. There are certain things that we know statistically certain genders, certain groups are more susceptible than others. But it's when we have this us versus them, the oppressed versus the oppressors, this type of language that I think really takes away from the fact that everyone's human. And that's what we're trying to do, is help people. So that's my talk. I'm going to go run back to class right now on clinical psychology. Thank you, Justin, for
So as was indicated, Dr. Annotate will be at U of T on March 21st, giving a talk on why men don't ask for help and how we can change that. So it's very similar to tonight's theme, but there at the University of Toronto. So we're going to turn out more to talk about solutions, and as I said, we're going to be hearing from agencies that have been doing some great work in the community, and we're going to be hearing what they're bringing to this topic. But first, from the Center for Men and Families, this is a little video we put together which talks about some of the mental health programs that we have, some of the programs for male survivors of sexual abuse and domestic violence and other forms of trauma. We have a legal clinic that we run there for men who can't otherwise afford access to legal support. It's a whole number of services that seek to fill gaps. That's the key thing, is we identify gaps and we try to fill them so that more people get the support that they need. So it's a 4-minute video, and then I will call up our distinguished panelists.